Hi, very good morning. I am Dr. Janak Patel, MD, General Physician. Today we'll be discussing on the another part of pericardial disease, that is cardiac tamponade, or we call pericardial tamponade. So two common words which are being utilized: cardiac tamponade or pericardial tamponade. Majority of the thing we have already discussed in pericarditis and pericardial effusion, but this will be little repetition of good number of things. But as this is an important thing, if you diagnose them early, if you treat them early, you reduce your mortality. So from that point of view, we are discussing. So what is cardiac tamponade? It is accumulation of fluid in pericardial sac, which is sufficient to cause serious obstruction to the inflow of blood into ventricle, resulting into cardiac tamponade. Or more simplified form, it is a compression of all cardiac chamber due to excessive accumulation of pericardial fluid leading to compromised cardiac output. Or we can say that it is a life-threatening, slow or rapid compression of a heart due to pericardial accumulation of fluid, maybe pus, maybe blood, maybe clot, or maybe a gas as a result of effusion, trauma or rupture of the heart. But basically it is a collection of a fluid in a pericardial sac which results into compression or increased pressure from outside, which does not allow the cardiac chamber to fill during diastole. So there is a collection of a fluid which puts the pressure on the heart and which prevents it from pumping effectively. So it is a compression of the heart due to fluid accumulation within the pericardial sac. So this is the pericardial sac where the fluid is accumulated. It does not allow the ventricle to fill properly, and filling takes place during diastole. This is one way in which the filling of the cardiac chamber is affected. One is cardiac tamponade, second is constrictive pericarditis, and third we call effusive constrictive pericarditis. In all these three conditions, there is a restriction or there is a effect on filling of ventricular chamber during diastolic period. And this slide we have already shown you in a pericardial effusion that 150 ml collected during acute or in a chronic, even it can go up to 1000 ml. And when it goes to 2000, it becomes dangerous because it will produce cardiac tamponade. Usually if there is a rapid accumulation of a fluid, then it can result into decreased cardiac output, mean arterial pressure will fall, central venous pressure will rise, and you will have a backstride very frequently, and slowly the heart rate will decrease. This will be very common thing which will be happening because of rapid accumulation of fluid or massive. So in a case of an acute pericarditis, if there is a rapid and massive accumulation of fluid, it will result into cardiac tamponade. Also in case of a traumatic injury, hemopericardium can occur, and that will be rapid accumulation of a blood like stab wound injury, bullet injury, post-surgical following a biopsy or pericardiocentesis. Once in a while, rupture of ventricular aneurysm or acute MI, there is a rupture of ventricular wall. Occasionally in bleeding disorders, or it can be because of rupture of aortic dissecting aneurysm. Very rarely it will occur in tubercular pericarditis or pyogenic or idiopathic variety. Not very common. Yes, in neoplastic variety it can occur. So these are all the conditions which can end up with pericardial tamponade, multiple conditions. Majority of them we have already mentioned: malignancy, HIV infection, bacterial, viral, tubercular, occasionally fungal, drugs, post-coronary intervention, particularly coronary dissection or perforation, traumatic injury, post-operative, post-myocardial infarction, rarely connective tissue disorders, that is not common, radiation therapy, biopsy, uremia, idiopathic pericarditis, complication of surgery, and pneumopericardium due to mechanical ventilation, rare conditions. But some of those are very common like malignancy, post-surgical traumatic injury, etc. Most common cause bacterial, tubercular, hemopericardium, which can be traumatic, iatrogenic or aortic dissection, HIV, dialysis associated uremia, malignancy, etc. are most common. These are some of the uncommon causes like viral infection, post-MI, post-cardiotomy or cardiac transplant, autoimmune, drug-induced, etc. Acute tamponade is more common with traumatic injury, while subacute is very common with infection, malignancy, post-MI, uremia, drugs, etc. We already mentioned the common conditions like bacterial, tubercular, hemopericardium, which can be three common traumatic, iatrogenic, aortic dissection, HIV, uremia, malignancy, dialysis associated, quite common. Acute cardiac tamponade can be from 5.5% to 5.8%, means approximately 6, while slow cardiac tamponade incidence is less, up to 2.6. It will take 5 to 7 days after surgery, while this will be in a short period. Delayed diagnosis is because of low index of suspicion, because they present with a clinical picture which is almost like congestive heart failure or pulmonary embolism, etc. There is one condition where you can get a recurrent tamponade, very classical in case of pericardial window which gets blocked, sclerosing pericardium, pericardioperitoneal shunt, and pericardiectomy. In this condition, you can come across recurrent tamponade. What exactly is happening in this? Either because of rapid accumulation, even with a small quantity of fluid, it will create a marked increase in intrapericardial pressure. Or with slow accumulation, large quantity of fluid, say 2 liters of fluid, it will create severe increase in intrapericardial pressure. This pressure becomes more than right ventricular diastolic pressure. So it will compress the right ventricle, which will be squeezed, which will not be allowed to relax during diastolic period. Hence the ventricular filling will be very poor. So blood coming to LA and LV will be very low, which will give rise to marked decrease in cardiac output, and that will end up into severe fall in blood pressure and shock stage. So decreased expansion of cardiac chamber due to elevated pericardial pressure. The venous return to the right side during inspiration will be reduced, and there will be increased return necessary to compromise the diastolic filling of LV during inspiration. So in acute cardiac tamponade, even 150 ml can end up. In chronic cardiac tamponade, more than 1000 ml will end up with cardiac tamponade. So increase in pericardial fluid, increased pressure on the right side of the heart, decreased venous return, pooling of the blood in the pulmonary capillary, decreased stroke volume, decreased cardiac output, and person goes into a shock stage. Even sometime person can go into what we call as cardiac arrest. When it is acute, it will go into cardiac arrest very soon. So because of diastolic filling, decrease in systolic volume, decrease in cardiac output, increased venous pressure, systemic congestion, and pulmonary congestion. Decreased output will result into hypotension, shock and reflex tachycardia. Systemic congestion will result into elevated JVP, hepatomegaly, ascites and peripheral edema. And pulmonary congestion will result into basal crackles, or we call RALs. So decrease stroke volume, decrease cardiac output, hypotension, shock and reflex tachycardia. Increase venous pressure, pulmonary congestion, RALs. Increase pressure in the superior vena cava, inferior vena cava. Increase JVP, that is jugular vein dilated, hepatomegaly, ascites and peripheral edema. So even a small quantity of fluid, when it is rapid accumulation, it will result into marked increase in intrapericardial pressure. While slow accumulation with say 1 liter of fluid, it will produce equal pressure elevation. But it will be a large quantity of fluid. Here even a small quantity of fluid as less as 150 ml or 200 ml which can produce increased pressure. And because of that, there will be decrease in cardiac output resulting into fall in systolic blood pressure and diastolic blood pressure. So there will be fall of systolic as well as diastolic, leading to narrow pulse pressure. So systolic pressure will drop, right ventricular systolic pressure will also drop, and that will give rise to fall in blood pressure as well as cardiac output. I'll show you the diagram in next, which is more simplified. So at the end of expiration, normally RV pressure is equal to LV pressure. During inspiration, the venous return to the RV is more. So that will shift interventricular septum towards left side. Because of this, the LV filling will be poor, cardiac output will drop. During expiration, more venous return from lung into LA and then into LV. So there will be increase in cardiac output during expiration. This will give rise to classical pulsus paradoxus. Hence, during deep inspiration, the pulse volume will reduce and may even become absent. And during expiration, the pulse will slowly reappear. That is very characteristic of what we call as a pulsus paradoxus in cardiac tamponade. Or if you measure the blood pressure during deep inspiration and if there is a fall of blood pressure more than 20 millimeter of mercury, again it is suggestive of pulsus paradoxus, which is very classical in case of cardiac tamponade. In chronic stretching of the pericardium will result into stress relaxation. Because there is a slow developing of effusion, usually they do not develop tamponade. But when the large quantity of fluid gets accumulated, now intrapericardial pressure will increase and that will end up into cardiac tamponade. Usually in a cardiac tamponade, there are some symptoms which are very peculiar. Person will be anxious, apprehensive, ashen gray faces, cold clammy extremities, tachypnea, tachycardia, jugular venous pressure is elevated and jugular vein is distended. You will not be able to locate the apical impulse, and even if you auscultate on the cardiovascular system, heart sounds are muffled or sometimes it is almost inaudible. Rub is never present. There will be severe peripheral cyanosis. You may be able to demonstrate Evart's sign, where we say that there is a bronchial breathing on the left side below the scapula, and on percussion there will be a dull note. very characteristic because of compression of the lung. So the most common sign, if you see, which is presenting in a cardiac tamponade, is elevated GVP almost in all cases. Pulsus paradoxus is almost in 98%, tachypnea and tachycardia in around 80%, fall in systolic blood pressure in 36%, almost muffled heart sounds to absent or not audible heart sound in 35%. Rub will be very rarely auscultable, almost it is not present, and there is a rapidly falling blood pressure in 25%. Apart from those, person can present as dry cough, hoarseness, dysphagia, early satiety, nausea, abdominal pain. These are some of the symptoms which you can see in case of, which we call as a non-specific or non-sensitive symptoms and signs in case of cardiac tamponade. So these are a big list which can be present. Now, apart from those classical symptoms, there can be some symptoms which are secondary due to the basic etiology like malignancy, where person can have a weight loss, fatigue, anorexia. In connective tissue disorder, joint pain, signs of uremia in case of a renal failure, skin lesions related to drugs we can call lupus, or recent procedure which has been done like pacemaker or central line, which is suggestive of iatrogenic, which is post procedure trauma. Tuberculosis, low grade fever, evening rise of temperature, night sweats, usually in radiation induced etiology. There will be history of cancer and person has been subjected to radiation as a chemo or a radiotherapy, etc. One classical sign we call as a Beck's triad, which is very common in a cardiac tamponade. We call hypotension, JVP distension, muffled heart sound. This you should not mistake because similar finding you come across in a tension pneumothorax where you get hypotension, JVP distended, and there is an absent breath sound. Heart sounds are heard. So very easy to differentiate. If the heart sounds are not audible, almost nearly absent, more in favor of cardiac tamponade, and if the breath sounds are absent, it is more in favor of tension pneumothorax. And on ECG and in echo, you will be able to demonstrate in a cardiac tamponade pericardial effusion, the movement of the ventricle will be abnormal because ventricle will not be able to fill during diastole. You will be able to demonstrate that very easily in a echocardiography, and in ECG you will get a low voltage based electrical alternance. That is, alternate ECG will be of a different voltage, which is characteristic in a case of a cardiac tamponade. There is also another word which is being utilized is distended vein, decreased blood pressure, which is for hypertension. Distended vein is for raised JVP, and decreased heart sounds, or we call muffled heart sound. They call 3D, or we commonly use the word increased venous pressure, decreased arterial pressure, and muffled heart sound. Classical Beck's triad. So in case of an acute, Beck's triad is clearly present, while in subacute, usually it is with biventricular heart failure, more of right side heart failure as compared to left side heart failure. So that is quite common in subacute variety, while in acute variety, usually it is more frequently right side heart failure. In an early stage, you will have a mild to moderate elevation of central venous pressure. In advanced stage, there will be increased intrapericardial pressure, decreased ventricular filling, decreased stroke volume, hypotension, and impaired organ function. So typical elevation of central venous pressure. So clinically you will get, this will be different symptoms, chest pain, dyspnea, because of decreased blood flow to brain, near syncope, etc. And you will have a classical Beck sign or Beck's triad, pulsus paradoxus, tachycardia, on auscultation nearly absent heart sounds, and if you try to palpate, cardiac impulse will not be palpable. Friction rub is rarely audible. Pericardial knock will be present if there is constrictive pericarditis. S3 sound as such, because the heart sounds are so muffled, S3 sound will not be audible. This will be very clinically, you will be able to identify. You will have a hepatomegaly, pulsus paradoxus, Kussmaul signs may be present, which means paradoxical increase in jugular venous pressure during deep inspiration, and there will be absence of wide descent. Ewart sign, we have already told you that on percussion, you will have a dull note on left side posteriorly below the scapula. You will have a bronchial breathing with agophony, which is characteristic described as Ewart sign, and this is because of compression of the left lower lobe because of massive pericardial effusion leading to cardiac tamponade. This will be typical in a JVP, that is A wave will be markedly prominent and there will be almost absent wide descent. Wide descent will be very poor. There are two types of cardiac tamponade. One we call as a low pressure cardiac tamponade, where patient is severely hypovolumic. Intracardiac and pericardial diastolic pressure are only 6 to 12 millimeter of mercury, and this you will be able to demonstrate on echocardiography. Very difficult to demonstrate clinically. A fluid challenge test with a rapid infusion of 1 liter of isotonic saline will elicit typical cardiac tamponade hemodynamics. So this will be one of the tests which will help you to diagnose low pressure cardiac tamponade. There is one another variety we call it the regional cardiac tamponade, which will be very commonly because of localized effusion or loculated effusion, or we call localized hematoma, where you will have a selected chamber which is compressed, and that will be demonstrable very clearly again on echocardiography, where you will not have all classical symptom signs of cardiac tamponade. Invariably, a short note is being asked on pulsus paradoxus. So there are two methods of demonstrating pulsus paradoxus. One by blood pressure recording. So you record the blood pressure. If you are taking a blood pressure during inspiration, slowly the pulse disappears. So there is a fall of blood pressure during deep inspiration, and there will be fall more than 20 millimeter of mercury. The difference between the two record, if it is more than 10 to 20 millimeter of mercury, we call that as pulsus paradoxus. Because during forceful expiration, the cardiac output will increase, and that will bring back the blood pressure, while during inspiration there is a decrease in the cardiac output and there will be fall of blood pressure during deep inspiration, and that is the way you try to measure by blood pressure. When you feel the pulse, you ask the person to take a very deep inspiration. During deep inspiration, slowly the pulse volume will become low and almost it disappears, and during forceful expiration the pulse volume will recover again and you will have pulse coming back again. Pulsus paradoxus can also occur in a large pulmonary embolism, severe COPD exacerbation, labored respiration, constrictive pericarditis, restrictive cardiomyopathy, RV infarct, severe circulatory shock, massive pleural effusion, tense ascites, severe obesity, etc. Pulsus paradoxus can be also associated with asthma and pulmonary embolism. There are some conditions where pulsus paradoxus is present, but still it cannot be demonstrable clinically, like localized pericardial effusion, aortic regurgitation, ASD, severe RVH, LVH, and elevated left ventricular and diastolic pressure. In this, you will not be able to demonstrate pulsus paradoxus. It will mask. Even if there is a pulsus paradoxus which is being present, it will be extremely difficult. You will be able to demonstrate only by echocardiography. So, pulsus paradoxus, also called paradoxic pulse or paradoxical pulse. It is not paradoxic, but it is abnormally increase in stroke volume. Normal person also, there is a little fall of stroke volume during inspiration, and during expiration there is increase in stroke volume, but this become exaggerated. So normal fall of pressure is less than 10 millimeter, and when there is fall more than 10 to 20 millimeter of mercury, we call that as pulsus paradoxus. So pulsus paradoxus is exaggeration of normal inspiratory decrease in blood pressure, and if there is a drop more than 12 millimeter during inspiration, it will go in favor of pulsus paradoxus. We have already mentioned that it can occur in person with severe asthma, pneumothorax, pulmonary embolism, COPD, etc. But you will not be able to demonstrate pulsus paradoxus in presence of cardiac tamponade because of presence of LV dysfunction, aortic regurgitation, or ASD. Pulsus paradoxus, tamponade without pulsus, we already mentioned. ASD, aortic stenosis, aortic regurgitation, LV dysfunction, or severe hypotension, or low pressure cardiac tamponade. And pulsus paradoxus may be there without tamponade, like COPD, RV infarct, pulmonary embolism, effusive constrictive pericarditis, restrictive cardiomyopathy, obesity, tense ascites, etc. We call pulsus paradoxus is there, and there is no cardiac tamponade. So we have already mentioned all those things. As far as investigation is concerned, mainly EKG, which will tell you low voltage pulsus alterans, or we call electrical, sorry, not pulsus alterans, electrical alterans. Chest X-ray will demonstrate there is increased cardiomegaly, increased size of the cardiac shadow. Echocardiography will demonstrate clearly pulsus paradoxus and evidence of cardiac tamponade. Right heart catheterization may be helpful. So echocardiography, pericardiocentesis, and biopsy will be very, very helpful. And you will have to investigate to find out the etiology of cardiac tamponade by means of pericardiocentesis and pericardial fluid examination. CT MRI may be helpful. So usually diagnosis of cardiac tamponade is done by symptoms, ECG, echo, and cardiac catheterization. We already mentioned before. So at your leisure time, you can go through this particular slide. I am skipping this particular slide. You can see this massive pericardial effusion. Chance of cardiac tamponade will increase. We call globular heart or a bottle shaped heart. So severe cardiomegaly, You can go for pericardiocentesis and pericardial fluid examination to find out the etiology. On an ECG, you will see low voltage with electrical alterance, quite common. Echocardiography is very much informative and confirmative, where you get a pericardial effusion, right atrial collapse, right ventricular collapse during diastole. There is one peculiar word utilized is called swinging heart, and respiratory variation of tricuspid and mitral valve flow velocity during inspiration and expiration. So echocardiography is very, very characteristic. Ideally, you will have to differentiate cardiac tamponade from constrictive pericarditis and effusive constrictive pericarditis. Also, you can pick up by echocardiography low pressure cardiac tamponade or low pressure and localized. That can be differentiated by, we call low pressure tamponade, hypertensive cardiac tamponade and regional cardiac tamponade, which you will be able to differentiate by a good echo. Also, you will have to differentiate effusive constrictive pericarditis from constrictive pericarditis, restrictive cardiomyopathy, and classical cardiac tamponade. Cardiac tamponade, you will have to differentiate from constrictive pericarditis, that is, in cardiac tamponade, there is a low cardiac output. Also, in this case of it is low cardiac. JVP is distended. Here also it is distended. In cardiac tamponade, you will not be able to demonstrate Kussmaul's sign, while Kussmaul's sign is a very characteristic of constrictive pericarditis. There is an equalized diastolic pressure. Here also there is an equalized diastolic pressure. RA is in right atrium, there is a blunt of wide descent, while in case of constrictive pericarditis, there is a very rapid wide descent, which you can demonstrate clearly. There is a decreased heart sounds in cardiac tamponade, while in constrictive pericarditis, you will be able to auscultate pericardial knock. Pulsus paradoxus will be typically present in cardiac tamponade. It may be present or usually it is absent. Echocardiography will be very helpful, and pericardiocentesis is a treatment in case of a cardiac tamponade, while pericardial stripping is necessary in case of constrictive pericarditis. This is a difference between all the four conditions. I am not going into detail at present. That is cardiac tamponade, constrictive pericarditis, restrictive cardiomyopathy, and RVMI. If you are interested at your leisure time, you can go through. It is a good slide. It will give you an idea regarding difference between cardiac tamponade, constrictive pericarditis, restrictive cardiomyopathy, and RVMI. So one of the important thing is Kussmaul's sign, which will be present in constrictive pericarditis, and it will be also demonstrable in RVMI, but it will not be present in cardiac tamponade. While ECG changes, that is electrical alternance, will be present in cardiac tamponade, it is absent in case of all other three. These are some of the peculiar findings you can come across. So always try to look for that. In cardiac tamponade, immediately you will have to go for pericardiocentesis. Try to find out the basic etiology and treat the basic etiology. If there is an infective pathophysiology like tuberculosis, bacterial infection, you should go for pericardiectomy. Surgical intervention may be required in case of rupture of ventricular aneurysm, dissecting aneurysm, post-surgical like CABG, post-pericardiocentesis or step wound injury, bullet injury, etc. You might require surgical intervention. As far as medical management is concerned, oxygen in case of hypovolemia, IV fluids, but in case of normovolumic, you do not require an IV fluid, bed rest, leg elevation. If there is a severe fall of blood pressure, you might require inotropic drugs like dobutamine. Mechanical ventilation may be required in some of the patient. So Usually in cardiac tamponade, you are suspecting bacterial infection or neoplastic etiology. Pericardiocentesis is a must to find out the etiology as well as for therapeutic purpose. If there is no elevated marker, then you can go for anti-inflammatory therapy. And if there is an elevated marker, which is no, so if you do an CRP, HSCRP, if they are elevated, you will have to go for anti-inflammatory therapy like steroids, colchicine, aspirin. And if it is normal, you can go for finding out the etiology and then treat the basic disease. If there is more than 20 millimeter of pericardial effusion, you can have a follow-up, and if it is more, if it is for longer period, you can go for pericardiocentesis or for drainage. In a traumatic variety, you will have to put either thoracotomy tubes, or you might have to treat tension pneumothorax if it is associated, pericardiocentesis, and good number of times you might require even surgical intervention. And in some of the cases you may require thoracotomy or pericardiotomy depending upon what is the etiology and what is the amount of damage. By and large, in case of severe shock stage, you require inotropes with or without vasopressor drugs. Pericardiocentesis is required to find out the basic etiology, very, very important, as well as it will help to reduce the intrapericardial pressure. So pericardiocentesis can be done echo-guided or ECG guided or as a blind procedure. By and large, echo-guided is most commonly utilized. You can go sub-xiphoid approach or parasternal approach, any one of those. So it can be blind procedure, ECG guided, echo guided or CT guided, and you can perform even a balloon pericardiotomy, or surgically you can go sub-xiphoid pericardial window you can create, or pericardiectomy you can do depending upon the requirement. It can be closed or open. Nowadays most commonly which is being done is a closed pericardiocentesis. It can be for diagnostic purpose, it can be for therapeutic purpose. So surgical intervention may be required if there is an associated other conditions also. This is parasternal approach. This is apical approach, and this is subcostal approach. This is subcostal approach, or we call xiphoid approach. This is ultrasound guided, and this is open pericardiocentesis. You can create a pericardial window by balloon dilatation of needle pericardiostomy, or you can go for sub-xiphoid surgical pericardiostomy, or you can go for video assisted thoracoscopy with localized pericardial resection, etc. In case of recurrent effusion, you will require pericardiectomy, or sometimes they go for pericardial peritoneal shunt, and you can also go for pericardiodesis, where you inject steroid, tetracycline or any anti-neoplastic drugs into pericardial space and produce sclerosis. Complication of the procedures: very frequently you create a myopericardial puncture or laceration. Vascular injury because you damage coronary blood vessels or intercostal arteries. When you are going through abdominal xiphoid procedure, you can damage intra-abdominal vessels. You can create pneumothorax very frequently in a parasternal procedures. Air embolism, arrhythmia because of damage to the ventricle. You can damage the organ like liver, quite common. and person can develop vasovagal shock due to pericardial decompression. So vasovagal response can be there in good number of people when there is a sudden decompression. And you may fail to relieve loculated effusion in case of acute hemopericardium. Contraindication, actually there is no contraindication for pericardiocentesis in Temponade. But if a person has got coagulopathy, you will have to be very, very careful. And if it is due to aortic dissection, dangerous one. Complication because of cardiac tamponade is acute congestive heart failure, shock stage, and mortality, very, very high mortality. So take home message, rate of development of pericardial fluid will determine the symptom, signs and management and severity of the disease and mortality. Don't give beta blockers and diuretic to a suspected patient of cardiac tamponade. Pericardiocentesis is a life-saving in cardiac tamponade. I thank you all for spending time with me. I know that your time is valuable. I hope this topic may be helpful to you in your everyday practice. So I end my lecture here.